Medicine was always something around my childhood and I grew up. I learned about this field called pain management from an independent practitioner out there along my journey. I think that pain management is a human right. Healthcare is always changing. And I've always had a mindset of I am going to establish a practice that is my own. What if we were able to harness and capture the way our body uses to heal, access and the retrieval of the most viable biologics came from the umbilical cord blood. I do this here in Orange County. I've been doing this since 2014. The post-treatment recovery period has got to be present. You got to respect that. I'm a strong believer in that this is a utilized, effective, proven way to target tissue inflammation and therefore pain can improve someone's functionality and quality of life. It's been 7 years since I first met you, but every time I see you, you just have that grace about you that always brings a smile to us. Yeah.
Thank you. We would love for you to share how you got into pain management.
Oh man. So I am a regular guy who's just essentially wants to be stubborn enough to take down a path of interest and curiosity. I've always been interested in sports growing up, and I've always been active, done snowboarding, mountain biking, and got involved with high school sports, tennis, golf, baseball,
running too.
I found myself doing triathlons, and then I went forward and did an Ironman in New Zealand, and had a lot of interest in activities on a personal level. Starting out, I've always grew up around healthcare because my father is a practicing internal medicine physician. So the exposure of medicine was always something around my childhood, and I grew up knowing the lifestyle and what he did and meant for patients. However, I wanted to figure out a way to get involved with interventional or a procedural based kind of practice of orthopedics, but not fully fledged surgery so much or clinical medicine. And I learned of a field when I was young in my medical journey, and I learned physical medicine and rehabilitation was a field when I was in medical school. Mm-hmm. That led me to capture all of those interests. And so I pursued a field that I didn't really have a lot of exposure to, in my pre-medical journey or pre-medical school journey. I learned the basics and the sciences. And then in medical school, I learned the cores, which is like, you learn about the first year is, the normal and how the body works. And then the second year is about the abnormals, and mm-hmm. then, the pathology and the pathophysiology. And then what I learned was in third year, you go through surgery and you go through internal medicine and obstetrics and pediatrics. But I learned about this field called pain management from just kind of a independent practitioner out there along my journey. And he told me a little bit about it, and I was captured by the fact that how many people I knew in my life had suffered from musculoskeletal pain or chronic pain, whether it's spine pain or joint pain or cancer pain and just kind of also let you know, I am Iraqi. So I am Iraqi American. And so growing up and through my medical journey, of course, Gulf War I and the sanctions in Gulf War II. And my parents are, from Iraq, and I was born in Iraq, but moved to the United States when I was younger. Mm-hmm. So I have been exposed to a lot of unnecessary post-war pain, musculoskeletal injuries, depleted uranium blasts and injuries, amputations and things like that. So it kind of segued into my calling. I think that pain management is a human right. I think everybody should have access to managed pain control. And I was more curious on like, why is there not a specific understanding and field of that? So I basically, stubbornly went down a path of, this is what I want to do, and nothing else mattered, get out of my way approach. I just said, hey, this is it. This is like, I think that this is my calling, and I'm going to be the best at that, and be driven towards this goal of like, there is a way. Maybe I cannot potentially cure people, but I can functionally change their quality of life. And that was my my mission statement, and in terms of trying to achieve that. So
how many years have you been in pain?
So here I am. I went to medical school for 4 years, and then essentially did a surgical internship, trained in Atlanta and at trauma, Grady Hospital. Went to do a 3-year residency in physical medicine rehab at Georgetown. And then from there, I did a 2-year subspecialty in pain medicine and pain management, interventional spine. So 4 years plus an additional 5 years. And that led me to, sit for my PM&R boards, and I got boarded in that. And then my PM&R boards, physical medicine and rehabilitation, took my oral and my written exam and my oral exam, passed that. Then I did my pain boards, and I then passed that. And so since 2014, I completed the training aspect. So that was all on the East Coast. So yeah.
And then did you open up your own clinic right away, or worked in the hospital?
Yeah, great question. So healthcare's always changing. Man, it's always changing. So it's about keeping up with the changes. And I've always had a mindset of, I am going to establish a practice that is my own. And I looked at it as, this is the way I choose to treat the patients that I will one day have, and under my specific criteria, my energy. And I'm not going to be a part of a level of a grander institution that's going to dictate the way I can freely treat my patients or future patients. So I opened up something called Pacific Pain and Regenerative Medicine in 2014 on a piece of paper, scratched it all up, and created these logos and ideas and color schemes. I'm like, I'm going to do this. And I had no idea what I was doing. And I incorporated it. And that was 2014. However,
10 years.
Yeah. So it's 2014 is when I started, and now here we are, 2024.
And how many clinics now?
We have 2 main infrastructures with 2 satellite clinics. I have about 23 staff members. I have 2 other providers, another board certified pain specialist, as well as a nurse practitioner. We're bringing on more staff. We have 2 full-fledged surgery centers, and we are practicing. We're a pretty robust practice now here in Southern California, and expanding. So we're excited. We're excited, and it depends on the direction I'm looking to go. But my focus is the way we want to provide like years to life, as well as life to years mentality to the way we provide our care for our patients. And I think that pain management, it's a misunderstood sometimes. I think people think the old perspective is that it is a sit behind the desk and write controlled substances such as opiates and refill in 1 month. But it's so much more diverse than that. And so that was the the exciting aspect of educating that, hey, it's actually a multimodal, multidisciplinary approach to the management of musculoskeletal pain or chronic debilitating pain that affects patients or people's functionality or quality of life.
Yeah. And Pacific Pain is also a regenerative medicine clinic.
Yeah. So
how did you integrate that?
Oh my gosh. So back in 2009, this is where early on buzz talk about the aspect of, well, what if we were able to harness and capture the way our body uses to heal, and uses the approach of the method of, well, if I can understand the inflammatory process and capture the actual biologics that can be used to galvanize and expedite the healing process, well, then maybe we can find a solution to help reduce tissue injury or tissue inflammation through inflammation control. 2009, I had an attending who unfortunately is no longer with us, kind of galvanized the approach of utilizing prolotherapy way back in 2008, 2009, where you were basically utilizing an irritable normal saline solution to kind of cause a process to galvanize the recruitment of the inflammatory cells, and that then led on to the understanding that platelet-rich plasma was something that we knew platelets had these fantastic growth factors, and we were able to extract that from patients. Now remember, 09, 08 was starting to get the buzzword out, and the concept of stem cells was still relatively new, and that was something that I was very interested in. I'm like, well, wait a second, here we are. I'm in the orthopedic medicine space, which is a space that is unique. It's not full-fledged instrumentation-based surgery. It's not internal medicine clinic. Here's a prescription of a anti-inflammatory or a muscle relaxer. It's actually a minimally invasive interventional approach with the advent of image guidance, ultrasonography, fluoroscopic guidance. So here we are. I kind of found myself in the kind of a forefront of orthopedic medicine, which is exciting because I'm like, well, the patients I was seeing back in the days of Georgetown were actually the professional local teams, right? So the Nationals, the Redskins, and a lot of the athletes that were coming in, or the Commanders now. It's not the Redskins, but the athletes. I'm like, well, this is kind of what the field I really wanted to be. Listen, I'm only 5'8". I'm not, I'm not a professional athlete by God's design, but I, feel like I was always interested in the way to manage or see and treat those kind of sport-related injuries, which I'm always hearing about, and here I am practicing a clinical base with an interventional base and surgical base. So I use my training to just literally get technically sound in the spine, in the peripheral joints, and medicine was all integrated. And so 2008, I came out and I'm like, yeah, we already understand now, the science of mesenchymal stem cells is just the ability to extract them. In those days were not as available until fast forward 2, 3, 4 years. Yes, we were able to get, we understood that we could get bone marrow derived mesenchymal stem cells. We understood the adipose derived mesenchymal stem cells, which are viable options. However, there was the extraction of a numbers game. It was like, okay, maybe the actual live number of mesenchymal stem cells were not as effective. Also,
And the viability.
and the
probably.
viability factor. Where are we getting these from? Are we getting these from a 75-year-old
Yeah.
who has multiple comorbidities, endocrinopathies, has diabetes, blood pressure, a lot of different factors. So the quality, the viability of the extracted stem cells, mesenchymal stem cells, was not as effective from a patient outcome than what I have discovered umbilical cord blood derived mesenchymal stem cells. And that's where you and I kind of fell into that relationship. And I understand that the access and the retrieval of the most viable biologics came from the umbilical cord blood, the Wharton's jelly. So what I used was kind of like a perfect timing of like, wait a second, I'm trained, I understand, I can get inside someone's L4, L5 facet joint better than most people in California or in the country. I'm just like, I'm 12,000 spine procedures in. I know my way around. I know the anatomy better than a lot of my medical colleagues because of that's just my training, right? And so I understand the shoulder anatomy and the range of motion, and I understand the testing, and I understand the difference between a cervical spine pathology and how that can radiate out to the shoulder, as well as a shoulder can also be a referred pain to that area. And so it's about the right diagnostics, right diagnosis, right clinical touch. And then in the fellowship years was just like, okay, well, this is how you proceed under image guidance to inject whatever at that time. So I'm like, okay, I can do that, right? I can do a nerve block. I can use corticosteroid, or I could use platelet-rich plasma, or I could use bone marrow-derived stem cells, or I could use an umbilical cord blood mesenchymal stem cell. And, I've also, I'm starting to see these patients who are coming to me with these kind of ailments that are debilitating. And I'm like, okay, well, let's try the conventional standard of care approach. And we're like, okay, well, let's focus on, let's try those first. And if those don't work, then we can try this entire field that is promising and exciting and safe to try, right? So
first autologous and then allogeneic if that didn't work.
Yeah. And in fact, what I've learned early on was that autologous really didn't really have that much more added value after I become more comfortable with the allogenic, which is, getting it from a different donor source, because I'm like, this is now very, very safe, right? There's no,
less invasive to the patient.
Oh my God. Yeah. Less invasive. So you're talking about, you're talking about a spine, or you're talking about a procedure like a adipose-derived procedure, a fat-derived procedure. I mean, that takes, some anesthesia, that's preparation, that is, it takes time. And the end goal is the extraction of a viability of cells that, well, I could actually now with the resources around, we can get incredible umbilical cord blood mesenchymal stem cells delivered to the clinic in a very safe fashion, and use that as and extract that to deliver the target treatment. And I'm like, well, if I'm an orthopedist, or I'm a spine injectionist, or I know my spine or other soft tissues, then, well, what about intravenous use? Because of the way these work, right? So, stem cells, what's incredible about stem cells is that they have this paracrine signaling ability, so you don't have to be exact in terms of the target delivery of, like, let's say someone suffers a meniscal injury, and that meniscal injury is the medial meniscus, and it's in the back part of the meniscus. So it's like the posterior horn of the meniscus. Well, I don't necessarily have to make sure that the tip of the spinal needle or an injection needle has to be at that posterior target for the delivery of the stem cells. So because of the signaling ability, that can be helpful, and that's why, and the advent or the usage of intravenous approach to galvanize your own endogenous stem cells can be very effective in terms of the way it heals, or the way the body's mechanism to capture that ability to reduce inflammation and to for wellness, right? So this is where we're at. So, but that's kind of my journey in a sense. So I was like, well, I've always been interested in it, and it just kind of fell in my lap as a PM&R, physical medicine rehab specialist, and pain specialist and interventionalist. I'm like, yeah, this is not a problem. Then people have come to me from different regions and said, hey, well, I've read studies on, neurodegenerative treatments, in the neurodegenerative space, there's not a lot of treatment options that other than what we currently have, and people are dealing and suffering, and neurologists and their medical team have not been able to advance further the kind of things that we have, except for what we currently have. And and patients have this level of, I have a prognosis no longer than 6 months or a short period of time, and I don't know what to do, and they're open-minded, of course, and their internal medicine doctor and neurologists have cleared them from the discussion points of like, hey, well, I think it's okay from that perspective. I don't counter any of their medical opinions, but I'm like, well, what if we can introduce these stem cells, mesenchymal stem cells, in cavities that can cross the blood-brain barrier? And for me, I'm a spine specialist. I know how to get, I know crossing the ligamentum flavum. I can cross into the epidural space, the dura, and then cross into the dura and get into intrathecal. And I'm like, well, if I can introduce stem cells intrathecally, then then at that point, can't you deliver stem cells into the CSF fluid? Mm-hmm. And that's what I've experienced, doing that. And these patients who have been given a prognosis of 6 months are coming back to me every 6 months for the last 2.5 years. And so what we're able to do is, hey, look, I don't give them like this is a miracle. I say, look, this is considered investigational, experimental. However, there are mountains of data and evidence to show that it can help. And that's what I do. I don't state that this is the cure. Yeah. But when I'm in the room and patients are, hey, I don't know what else to do, these are the kind of serious patients I am seeing in my clinic, right? Or like I am, I have, very commonly, right? Like parents are concerned their son's looking to get this scholarship to go to a Division I wrestling team, and this shoulder's significantly affecting them. And, we've tried different kinds of treatments, and, we're really interested in seeing if we can help the healing process by trying regenerative options. And I do it through precision placement with X-ray guidance or fluoroscopic guidance, and I can get intracapsular, and we can do it. And then I tell them, like, this is one of multiple verticals in the way we manage this kind of this pain. So this has kind of been the joy of this process, and it's promising, and it's still promising, and it takes a little bit of curiosity and thinking outside the box. But as probably your audience and yourself and people are flying all over the world for mesenchymal stem cell treatments, people going to Mexico, the Caribbean,
Third
Colombia,
world.
third world, they're going to Europe. I'm like, I do this here in Orange County. I've been doing this since 2014. I just don't market it or advertise it because of the scenarios of, this is just, it's a safe treatment for the perspective I do, but I just tell them like, for whatever reason, there are bad actors out there who are,
For them, it's a business.
It's a business and they're fly by night, they'll open up a shingle and a lot of them are not board certified interventionalists trained, right? They're just a business.
Yeah.
They will hire someone to come in and do a treatment once a month or twice a month. And it's just businessmen who are, not really. But so from a musculoskeletal specialist, this is something that, I offer for a component of my patient base.
What's a common misconception about regenerative medicine that you run into?
Yeah. So stem cells it's a buzzword. People are requesting, a level of superhuman ability to go back to a level of, they come to me with moderate to severe spine changes, stenosis, have had, 25 years of injury and have not really done the right components of the rehab and the care that they should be doing. And they think that these stem cells are going to be the cure-all.
Yeah.
So I think that giving the right expectation, curbing the expectation of my patients, saying like, look, I think that that's a part of the process. I think the research is kind of, we don't have robust, rigid, randomized controlled trial double-blind studies to really say, there's been studies out there that have been kind of soft and they kind of have, they kind of give the bad rep for that, so misconceptions are, like they don't work. But if you just go down to the science and the biologics, these are cells, right? So it's just more than that. So, these cells have the ability to signal, and let's just take them for what they are, right? These are biologics. Got to make sure it's minimally manipulated and make sure it's, you're not doing any kind of unethical extractions. But I think that we just have to understand that this is one of the verticals of treatments that is there I tell patients like, look, I expect these to be helpful, but I also want you to know that there are multiple factors in this. And I need you to understand that the post-treatment recovery period has got to be present. You got to respect that. You have to create an environment that's most important for the rehabilitation and the recovery. But I'm a strong believer in that this is a utilized, effective, proven way to target tissue inflammation and therefore pain, and can improve someone's functionality and quality of life. But it is sometimes it needs a maintenance treatment, or sometimes it needs other forms of modalities.
Yes, I know you and I are both. We've experienced stem cells ourselves. I do it every year.
Yeah.
But what is your favorite success story from a specific patient?
Like this one lady from Hawaii. She was diagnosed with ALS, and she wasn't given longer than 6 months. She's crying and desperate, and was a scenario where she flew in, and she's like, no, there's not a lot of adequate medical options for me. She has this this neurological disease. And I think that no one has given her a chance in the sense of what we could do to adequately give her that ability to treat. And you know, I think coming in, you know, she was excited. We underwent the interventional intrathecal delivery of stem cells, and she, you know, immediately, you know, wrote an email 3 months later. She's excited. She's doing more functionally. She's able to get some of her quality of life back. And a year later, you know, she's coming in for a second booster treatment, and now this is 2 years in, and she wasn't given longer than that. I've had post-stroke, significant moderate to severe hemiparesis and spastic patients at the same time, who are desperate, and they are in the middle of a region of the country, and they are not able to get adequate care, and they've through word of mouth have found that this is a potential option, and they flew in, and they were able to get treatments.
So you're able to do consults over the phone prior to them flying in?
Oh yeah. We you know, with the advancements and you know, what COVID has done with the telemedicine has completely revolutionized the way we do consults, right? And we have a complete setup in terms of we can provide a telemedicine consult and do this wherever they are in the world. I mean, I have patients who just came from mainland China, who, here's another one. So this is where the diagnostics really make a difference. I had a patient who literally came to me, said her elbow was in pain. She had a lot of elbow pain. And she came from mainland China, and her family doesn't speak much English. They had an interpreter, and then came into my room last week. She, I'm like, wait. And so a thorough musculoskeletal examination revealed that, sure, she had an MRI of her elbow. Someone ordered it preemptively. Had some mild to moderate medial and lateral inflammation, or epicondylitis, or like tennis elbow and golfer's elbow. However, if you really kind of discussed some things with her and specifically targeted the questions to reveal that she doesn't have just elbow pain. She had significant radiating referred pain down her entire arm on the right side and on the left side. And then on further question, you started learning that she actually has a musculoskeletal spine component. And she was, you know, there's these signs in clinical orthopedic medicine that kind of revealed that, hey, wait a second, her pain actually might be coming from the cervical spine and the lumbar spine, right? So, you know, I'm sure, you know, a lot of your audience probably heard of sciatica, right? So, you know, nerve related or nerve impingement that stems from the spine radiating into, you know, the lower extremity. And then all you had to do was open up the questioning, spend a little bit of time with the right questioning. You're going to open up an entire component or corridor of, actually, this is not an elbow issue. It's actually a bigger, more complex spine concern. So immediately I said, look, I don't think I could have done the elbow injection right then in the clinic. I said, I don't really think this would be the best value for you. I think the most important thing is let's get the appropriate MRI after the right, you know, consultation diagnostic testing. And then we ordered the MRIs, and sure enough, multi-level disc displacements and facet arthritis in the cervical spine and lumbar spine. And so now what you did was all of those MDs that she saw in mainland China, I mean, I wasn't the first. She must have seen 4, 5, 6, 7, 8 MDs. And for some reason, and it could be multiple things, but it's just that they focused on the wrong component. So I told her, look, I think this is actually coming from the spine and the cervical and the lumbar. And 4 days later, but actually, you know, 2 days before her flight back to mainland China, we did a robust mesenchymal stem cell therapy treatments for the cervical and lumbar spine. So I think that is something that will, at least for the component of, hey, you know what? Now she will open her perspective, as well as speak to the orthopedist or people back home, saying, look, this is actually a spine concern, and delivery of treatment needs to be addressed over in that side of things. And so I think that's a big part of it, right? Like, but there are some easy ones that are like, okay, I have knee issues, and after stem cell treatment, their knee pain significantly improved, and those are great home run stories. And ankle, ankle and hip joints, and any kind of orthopedic musculoskeletal. I have a lot of friends that are very active, play soccer, right, and play different sports, paddle or pickleball and tennis, and they come in for, hey, or I'm ready to entertain a tournament, and I want to be at maximal functional ability.
Yeah.
And so we'll tune up, in a sense, like we'll target those areas with a regenerative stem cell, like a mesenchymal stem cell or a platelet-rich plasma, or there's other components we can do, like different things like that are conventional, like radiofrequency ablations to these areas, so allow better range of motion. So
even exosomes.
My God, exosomes as well. I mean, exosomes is a big one. So exosomes, as you know very well, I mean, these are vesicles that are basically signaling from one cell to another. And in these vesicles, they contain these mRNAs, and that mRNA has like the blueprints to kind of signal to the receiving cell. Hey, like these are, the components of the cell that originated from. So mesenchymal stem cell exosomes can be very value added for the enhancements and the utility of tissue inflammation. And so, yeah, we do that. Exactly. Yeah. And intravenously or target. So like if you come to the practice, it's like, hey, I think an IV therapy plus a target treatment will significantly help. And one of the things I've been telling my patients, and I think Dr. Peter Attia talks about it in his podcast. He's like the decathlon, the centurion decathlon, and I'm using that in my practice. Is like, okay, I tell my patients, like, okay, when you achieve, we all hope you do, that you achieve 100 years old, that milestone. What are the 10 functional things you'd like to do when you turn 100? And I tell my patients that. You don't have to tell me now, but this is the kind of philosophical or approach or mindset to what we want to achieve in my clinic or my practice. The physical functionality, right? Some patients want to be able to pick up their grandchild or their great-grandchild or walk with their loved ones, down the street, or go to the grocery store, or play tennis or snowboard or ski or a lot of different things. So really it's about, understanding the biologics and all these tools that are there in our ability to treat all these patients' ailments and which are significant. And so am I curing them? No, but what I'm trying to do is just add, basically life to their years. That's kind of my mantra on that front.
Yeah, I think it's a delay in the disease process also.
Yeah.
You're a great voice of experience because you've tried it, and how has it helped you?
Yeah. So recovery. So
from triathlons?
So I went from couch deconditioned to running a full-fledged 140-mile Ironman in New Zealand. And I did that just because I was just, looking at it as like a situation. I was like, okay, well, I have the mental fortitude from the medical training pathway. The physical fortitude is like something that I was curious about, if I had it or not. regimented. So, the discipline of, okay, you follow just like for me in school, it was like, just give me the syllabus. I need to know what's the points, what's on the test. Let me do it myself, an approach, right? And, and you can find these kind of paths or these kind of guidelines through a training program in any specialized events, let's say. So I did one that was like, I don't know, 16 weeks long or 20 weeks long. And what I learned was when I started climbing in these mileages or times swimming, what I did was I'm like, well, let me introduce IV intravenous stem cell therapy for the recovery. And I will tell you, I mean, it's incredible. And I don't know if, maybe I didn't have like Olympic times, but I'm an MD with, private practice. I wasn't trying to break records here. I just wanted to cross the finish line, and I didn't really experience significant, knock on wood, of course, thank God, no significant musculoskeletal pain during my training or at the event. So I was like, and I think that I attribute that to like, being aware and in tune of my my body's signals. And so I've been doing, and I probably did an IV infusion on twice in that 1 year period. And I would say that the ability to manage any kind of musculoskeletal fatigue or injury or tendon inflammation or pain was really minimized. I remember the day after that Ironman, I was just like walking through the town and, was with my mom at the time and just walking through, and I was like, wow, I don't really feel terrible. And I just think that, that's how I use it. And I'm just like, I just use it for any kind of event. I do it once a year. And if I may switch that to a frequency of twice a year, and I'll continue to do it.
So your recovery was faster.
The recovery was incredible.
Yeah.
And I just really was like, wow, I'm not really I'm not feeling sore from the training. I mean, the training regimen, like you're waking up on a Saturday, you have a 20-mile run, and you're like, well. After that run, you go to your friend's, brunch party, and you're like, yeah, I just did a 20-mile run. It wasn't even bad. So the recovery was, was it attributed to the IV infusion of stem cells, or was it just like the awareness of my biomechanics, or maybe a combination, or was it a combination of my nutrition and my fuel and the way what I did? I was just hyper focused on the mechanics and using biologics because I was a big fan of it, and I am, and I will always be a component of an advocate for it. I think that was how I'm using it.
Yeah. Did you really say 140 miles?
I don't know. I mean, if you're, I guess it's like, okay, 2.5 mile swim, 2.5 mile swim, come out of that transition zone, get on your road bike. And it was in New Zealand. I'll never forget it. It was 140, I want to say 140 mile. I don't know. It was like 120. It was definitely triple digit mileage. And then when you finish that, you lace up and you do a full 26-mile run.
Wow.
And mind you, I'm not a runner. I'm not a swimmer. I'm not a cyclist. And I did it. And I run a practice. And that was kind of one of those things that I was like, you know what, that was, and I just was, I think that was the recovery was one of the factors that I want to attribute that to. And I'm looking forward to the next triathlon. Now I'm a family. I have a little one, and I have one on the way. So my free time has been kind of preoccupied with taking care of Saturday park days with the little one. So, but I do think that the regenerative medicine has been a big part of my my approach to recovery and wellness, I think.
I think I would have to agree with you because I had neighbors and they were a couple and they were triathletes. And after each event, they would be in bed for 48 hours.
Oh, boy.
They couldn't get up.
Yeah.
So for you to get up the next day.
It was, I'll be honest with you, it was, I was surprised. I was just like, hey, I just popped back up and just kept on going. And, we were touring the new town and it was like, yeah, it was incredible. I just, and the whole training period, I wasn't like, oh my God, I'm out for 6 days because of a really bad, lower back strain or like a, or a knee injury or anything like that. So I don't know. I'm not sure, but I would say that, just mindfulness and preparation. And in that preparation, I do think that incorporating a infusion therapy was a part of my experience. And again, like wellness is a part of the way I practice. I think I believe in the prehab as well as the rehabilitation. So like, mindful eating, conscious eating. So I consider myself a conscious eater. I try to minimize any, I'm plant-based in the way I approach my lifestyle in terms of what I use for fuel. It keeps me going through my clinic day. I see about 35, 40 patients a day.
Wow.
We run a pretty robust practice and it's, I can't, I'm always hyper focused about, optimal cognitive as well as focusing on the body as focusing on spiritually as well. So I think, it's been a very educational and very, but I also believe that this is a part of the future of sports medicine and interventional pain, and that biologics is going to be a big part of my practice, and I don't see it going away from my practice.
No, I mean, and this is why I feel comfortable with referring a lot of athletes and patients to you because you have such good experience in the way you explain, the misconceptions and
thank you.
Where do you see the future of Pacific Pain Clinics?
Yeah, so we are.
Are you expanding?
We are expanding. So I try to keep this with like in a organization where I don't have private equity coming in, but there are people who are interested in buying into the expansion of our practice. But really it's just about getting like-minded providers, proceduralists, and understanding that our focus, we're expanding. We're just like, we're getting involved with the medical legal as well. So a lot of naturally people who, who are dealt with whiplash injuries, car collisions, seek legal advice, and they end up having personal injury cases. And because I'm an interventionalist and I'm a pain specialist, I have found myself in that community to be a pain specialist that my attorney colleagues or friends or not friends, but everybody who's just like looking at us like, hey, we can help get our client recovery faster. So I do think that there is a space for regenerative medicine to be a part of the medical legal side. And we're already crossed the platelet-rich plasma management. I mean, I think I'm one of the first in the community that we're doing platelet-rich plasma in the epidural space, and we're seeing great outcomes, and patient outcomes are it's helping in that. So I think we're the growth of Pacific Pain is that we're going to move into different parts of California and who knows, go further from there. But really, like the understanding the utilizing the understanding of healthcare and science and medicine and where what the future is for stem cells or regenerative medicine is going to be something that we're always interested in. We kind of want to take the maverick approach on doing this safely, of course. But
yeah, it's a delicate conversation with patients. You just don't want to make any guarantees, and you want to avoid surgery if possible. With biologics.
Yeah, and post-surgical as well, right? So many patients have had surgery and the scar tissue developments, and I'm like, hey, look, we can help with the management of that scar tissue, and this is going to be ongoing. And we I think if my focus is a comprehensive rehabilitation facility. My goal is to touch every continent and kind of teach other future providers about what we've experienced and what we've seen, and implement maybe an acute rehabilitation, multidisciplinary, focal approach to pain management in the places I've traveled and helped, show them our infrastructure and our setup and do that is kind of what my future interests are in terms of doing that. So
luckily for my patients, they can find you in Orange County, in LA.
Yeah.
And then your website is?
Yeah. So we're currently in, our ecosystems currently are in Irvine, in Orange County, and Los Angeles. We are looking to expand into also the West Side, more in the Brentwood area as well as in the Inland Empire and Northern California, and we'll see from there. Our website is www.pacificpainfree.com.
Pain-free. That's the goal here. Thank you so much for coming today.
Thank you for inviting me and having me on.
Yeah, always nice to see you. I highly recommend his clinic. Always my number one doctor to go to.
You're too sweet.
For pain, not just for me, but for my family. So.
Thank you. That's very sweet.